Okay, so for those of you who are interested in orthopedics, the next few lectures are going to be quite interesting for you. Hopefully, even if you're not interested in orthopedics, the next several will still be interesting. But in any event, we're going to be talking today about the upper limb, and then we'll also be just at the very beginning here, we'll be just wrapping up and going through a short review of some of the spinal anatomy imaging that we talked about in the last module. So with no further ado, I just wanted to introduce a couple of terms that we had mentioned. One of them here is spondylosis that we mentioned in the previous unit. And so remember that this is the natural degenerative process of the intervertebral disc and the facets. So you'll notice that in this radiographic view, for example, you can see fairly large intervertebral disc spaces between C2, 3, and 4. But once you get down here to the intervertebral disc between C5 and 6 and C6 and C7, you can clearly see that the intervertebral discs have the space is significantly narrower, and so that indicates spondylosis. And then spondylolysis is the situation where the pars interarticularis has been fractured, and so you can see that quite clearly here. And so in some cases that'll cause an anterior displacement of the vertebra in this case of L4 on top of L5, and in that case we call this spondylolisthesis. So spondylolisthesis is the forward translation of one vertebral segment over the other after the spondylolysis has occurred. So you have to have bilateral fracture of the pars interarticularis in order for spondylolisthesis to occur. And so this is common in especially in athletes that have repeated high force impaction of the spinal column. So in people who, for example, athletes who engage in gymnastics, where you're constantly landing from height on your lower extremities, that's putting tremendous amount of force on the spinal column. Cheerleaders also frequently experience spondylolisthesis, where again, due to that repeated trauma, the pars interarticularis eventually breaks down, fractures, and then you get this forward translation of spondylolisthesis. So here's the way, just as an example of L5 on S1, what it typically will look like. And you can see how we are able to grade the different types of spondylolisthesis based on the severity. So grade 1, you can see you have about a 25% anterior translation of S5 on, or L5 on S1. Grade 2 is where you're around 50%, and then you can get even grade 3 and grade 4 where it'll translate even further than that. So anyways, most of them are going to be grade 1 and grade 2 though. Okay, so now we're going to move into the upper extremity, and so before we do that, just a quick reminder about long bones. You want to make sure that you are comfortable with the terminology of epiphysis, so that's going to be the articular end of the bone, the growth plate, also known as the epiphyseal plate, which is going to be where long bones grow from, and then we have the metaphysis as well as the diaphysis of the long bone as well. And so recall that if there's an injury to the growth plate in a child, that might cause growth arrest to occur, and so that's going to stunt the growth of that bone and cause abnormality in the length between the two extremities, which for the upper extremity isn't a huge deal, but if you do have differential growth of the lower extremity long bones, that's going to cause significant morbidity for the patient. So to review some of the important regions or bones of the upper extremity, remember that the upper extremity is anchored to the axial skeleton via the clavicle, and so we can see the sternoclavicular joint here medially, and then the acromioclavicular joint over here laterally with the acromion the acromion process of the scapula. So you can appreciate the scapula. You can see the glenoid cavity quite well right here, as well as the head of the humerus. And remember how that's sitting in that glenoid cavity. But you can also appreciate in this image the size difference between the glenoid cavity versus the head of the humerus. So the glenoid cavity is very narrow and it's and shallow, and it's much more narrow and shallower relative to the size of the head of the humerus. And so that's good in terms of allowing for maximal joint mobility, but it's not good for joint stability. So we're sacrificing stability in the interest of mobility of the upper extremity, which is really the opposite of what we see with the lower extremity. Here we have a labeled radiograph of the shoulder. So you can once again see the lateral half or so of the clavicle. You can see the acromioclavicular joint along with the typical size of or distance between the clavicle, the distal clavicle and the acromion process there. Here we can see the acromion process itself, the glenoid cavity located down here with the humeral head, the greater tuberosity of the humerus, and then you can also see part of the lesser tuberosity located right there. Coming more medially, we can see the coronoid process coming out of the screen towards you. And then over here, we can appreciate the ribs in this region as well, along with the medial border of the scapula. So you can kind of follow the borders of the scapula around on this image. There's the lateral border down there. Okay, so this will, the next several images will highlight the normal radiographic features of the shoulder. So it'll highlight each one. So here we have the distal clavicle highlighted in red. Then you can appreciate the conide tubercle. Remember, that's going to be the site of a ligamentous attachment point. Same thing with the trapezoid tubercle. We have the acromion process of the scapula, the coracoid process, and then the spine of the scapula. Here's the medial border of the scapula highlighted in red. So I'm going to go back and forth so you can appreciate how subtle that medial border is. You have to look pretty closely to be able to really appreciate that medial border. And then you can see the lateral or axillary border of the scapula highlighted in red there, along with the glenoid fossa, where again you can see just a small part of the humeral head sitting in it, and this resting position of this patient. And then greater tuberosity or tubercle, lesser tuberosity or lesser tubercle in this view. All right, so you probably recall from gross anatomy that the weakest part of the clavicle is going to be the junction of the lateral third and middle third of the clavicle, and this is actually the most common site of clavicular fracture. It's the weak point, and so it makes sense that that's going to be the most likely place that someone's going to fracture their clavicle. And so in this example, you can see here's where the sternoclavicular joint would be. You can see the acromioclavicular joint or AC joint over here. And so you'll note that the two sides of the fractured bone are well approximated. So in this case, we can probably just treat this patient with a simple arm sling, no need for surgery or any other more invasive treatment. Just simply immobilize the joint, or the shoulder joint, and instruct the patient not to move it, and eventually the two ends of the clavicle will grow back together. You'll probably get a pretty good fracture healing in that case. So something important to note is that these fractures are typically going to occur, and when I say these fractures, I mean fractures of the clavicle, are typically going to occur medial to the location of the coracoid-clavicular ligament. So the orange coloration here indicates the approximate location of the coracoid-clavicular ligament. So that's going to provide a fair amount of reinforcement to the bone. And so again, typically it's going to, the fracture will occur somewhere medial to that, or somewhere around the junction between the middle and lateral thirds of the clavicle. And then once again here, you can also once again appreciate the sternoclavicular joint. Here we have a fracture of the clavicle where you can tell that the two ends are not at all well approximated in this patient. And so typically when that occurs, this is going to require an open reduction internal fixation operation, also known as an ORIF. So that's where we open up the person and then we will reduce the fracture so that the two ends are approximated to each other, and then usually use plates or screws in order to fix the bone, the two ends of the bone in place in order to facilitate fracture healing. Okay, so this is a superior view now of the arm in a flexed and or abducted position. So in this case, the patient has flexed their arm, so they put their arm out in front of them, and now and then we're looking down on the glenohumeral joint. So you can see the acromion process coming out here laterally. You can see the glenoid fossa, the coracoid process, and the clavicle coming across right here. And then obviously the clavicle, or sorry, the humerus here with it. You can see the head of the humerus sitting in the glenoid fossa right there. And this is just another superior view. So now we can see a couple other features of the humerus well. You can see the lesser and greater tubercles or tuberosities. You can also make out the acromion process. And then also up here, you can see the coracoid process. All right, and this is another superior view, so we can see the distal clavicle as it's coming across and joining with the acromion process. The coracoid process is highlighted in red in this image. The body of the scapula you can see well appreciate here, along with the glenoid fossa, with the head of the humerus sitting right in that. And then you can see the acromion process. So note how the acromion process, you kind of see that in between the body of the scapula and the acromion process, you'll see this kind of a loop shaped, kind of like a C-shaped structure in here. So that's a good indication that you're looking at the acromion and the body of the scapula. And then remember the clavicle is going to be coming across in order to link up with the acromion process of the AC joint. And then here we have the scapular spine highlighted and the head of the humerus. Here in in this view, you can also appreciate the lesser tubercle or lesser tuberosity, and then the greater tubercle or greater tuberosity. All right, so looking a little closer at the acromioclavicular joint, the typical distance between the acromion and the clavicle is approximately 5 to 8 millimeters in most individuals. And so oftentimes what we'll do is if it's difficult to tell if it's normal, we'll do a bilateral chest or shoulder x-rays in order to be able to compare the size of the AC joint on one side, on the unaffected side, compared to the affected side. But again, typically you expect it to be about 5 to 8 millimeters. Remember that the corticoclavicular ligament is going to be the primary ligament that's helping to, or structure that's helping to reinforce or stabilize the AC joint. So the corticoclavicular ligament is comprised of two parts. You have the trapezoid ligament and the conoid ligament, and so those two together comprise the corticoclavicular ligament, and together they work to help stabilize the AC joint. Also note the horizontal relationship on an AP view of the shoulder. So the acromion process and the clavicle are in sort of the same horizontal plane with each other. And so if you note that there's a different, if they're in a different plane from each other, that's indicative of an AC joint dislocation. So in this example, we can see a grade 1 acromioclavicular sprain, where we can see that there's slight widening of the AC joint, but there's no displacement of the two components of the joint. So you can see the clavicle and the acromion, they're still in the same horizontal plane, but the distance between the two is just a little bit widened, and so that indicates a grade 1 injury, which is the least severe. And then this is the contralateral side for comparison, and here you can see the normal distance between the distal clavicle and the acromion process. Here's a grade 3 AC sprain, so this is the most severe, where now you can clearly tell that there's been disruption of the corticoclavicular ligament. So both the trapezoid and conoid ligaments are going to be torn in this case, and so you get this very significant widening of the AC joint space. And then you'll also notice now the horizontal plane has been disrupted as well. So clearly the clavicle's in a different horizontal plane than what the acromion process is. And so that indicates a very severe or a grade 3 acromioclavicular injury. And so again, in this case, not only has the joint capsule been broken or torn, but so has that corticoclavicular ligament. And that's what this image down here is demonstrating.